It's my pleasure as a nephrologist to introduce an endocrinologist from the University of Toronto, Alice Cheng, whom I've met for the first time today in face-to-face, although remotely at a meeting that we held, similar meeting to this, but essentially based in Toronto, remotely based in Toronto, and she gave an excellent talk at that meeting, so very pleased indeed to welcome her here. Now, she's going to talk about SGLT2 inhibitors, and of course, as an endocrinologist, those would have been almost exclusively in her domain when the story started, but increasingly, I have to say, being taken over by people like me from the nephrology wing. I'm very pleased to note that, and I hope everybody else does as well in passing. But essentially, this is a class of drug that just crosses over more and more specialties as time goes on. 3 major ones so far, but there may be more. Anyhow, Alice, very welcome here.
That's great. So thank you very much, Professor Cunningham and Professor Yellen, for the kind introduction and as well for the opportunity to speak to this esteemed audience. I was given this title, which I thought I would have some fun with, because the title is SGLT2 inhibitors, or SGLT inhibitors, are there no therapeutic limits? So these are my disclosures. Now, as I went on the internet and I thought I would Google what exactly, if you put in no limits, what in fact comes up. And this is the image that comes up. Now, growing up in North America, I had no idea what this image was. Does anybody know what this image is? From the Autobahn. I'm looking here at Christoph, who would obviously know this image. So this represents the section, I guess, of the Autobahn where you can drive without any speed limit. So that's really the question here when we're thinking about SGLT inhibition, is are there in fact any therapeutic limits? And it seems like there are none, because every day you turn on Twitter or you take a look at PubMed, you see another publication of things that have come that have now been positive with SGLT inhibition. So I'm waiting for one day finding out that it in fact cures everything under the sun. But at this point, what I wanted to do was share with you some of what we do know about SGLT inhibition. And as has been alluded to already, SGLT2 inhibitors were born in the diabetes space. So I think for all of the endocrinologists in the room, we are proud to say that this is where it was born. This was where it started. But obviously, SGLT2 inhibitors have grown up beyond the diabetes world and have made friends in other therapeutic areas and are helping people in other therapeutic areas. And you're all familiar with the series of trials that have come out around SGLT2 inhibitors that have truly expanded the therapeutic areas and the kind of people that we can help. And in fact, there are people in the audience who likely helped generate these data. So what I'm not going to do is go through any of these trials with you, because I think you have all helped generate the data, you're already using the data, and I think you've already heard a bazillion talks about this. But we know that these trials have in fact modified guidelines from around the world. This is by no means an exhaustive list, but major guidelines from around the world, not just in the diabetes space, but also in the cardiovascular and the kidney space. So clearly have made changes. But the question is, are there other organ systems that SGLT inhibition could in fact be looked at in order to provide benefit? Now, if you take a look at the complexity of why it has been postulated SGLT2 inhibitors have created all these benefits, you get figures like this. And if you PubMed search it, you get many review articles written by very intelligent people and very sound arguments for any of the components that are shown here. But when you have something that has such wide reach in terms of potential mechanisms, you can imagine it may affect other organ systems as well, and there may be other patients that can in fact be helped. So let's start off then with the brain. So if we start off with the brain, I think the first question we might want to answer is, okay, does SGLT live in the brain? And in fact, it does live in the brain, SGLT1 as well as SGLT2. And then, of course, your next question should be, okay, so then do the medications get to the brain? And the answer there is also yes. So if you think about the brain to serum ratio, it ranges from 0.3 to 0.5. So not a lot, but some do in fact get into the brain, and there are in fact these transporters in the various parts of the brain. So is it possible then that SGLT2 inhibitors could in fact be beneficial? And to help answer that question, we'd first sort of need to see, well, what is the problem that is resulting in the cognitive impairment that some of our patients may in fact experience? And you'll see words on this slide that have already been explained in great detail in this conference, such as inflammation and atherosclerosis. So clearly atherosclerosis plays a big role, inflammation plays a big role, M1 macrophages, activation of certain transcription factors, etc. And you'll also see NLRP3 inflammasome listed up there, which in Alzheimer's dementia is felt to potentially be a link between systemic inflammation and neuroinflammation. And the neuroinflammation may then impact the removal of beta amyloid, which, as you know, with deposits of that may actually, or not may, has been associated with Alzheimer's dementia. So then the question is, can SGLT2 inhibition potentially affect these pathways? And then the answer, by virtue of me bringing this up, is of course, yes, it's possible. So in animal models, SGLT2 inhibition have been associated with reductions in inflammation, NLRP3 inflammasome inhibition, increase in M2 macrophage polarization and therefore downregulation of STAT1, the transcription factor that is pro-inflammatory, and reductions in oxidative stress, which therefore, in theory, with SGLT2 inhibition may help with these processes in the brain. Now, remember, these are animal models predominantly. And Professor Drucker has to fly back home, but I think he would be very mad at me if I did not show you that little symbol on the top, that we always need to be wary of what we know from animals before we extrapolate that to humans. And then, of course, are there other pathways that we should be thinking about? And there's the mTOR signaling pathway, which is usually cyclical. And it's sort of a cellular way to that link between the energy status and local nutrients. And in the situation up top left of overnutrition, physical inactivity, then you end up switching the energy balance, and then mTOR signaling is hyperactive in an unrestrained fashion without the usual cycling. And then that then results in all these negative things here: endothelial dysfunction, increased oxidative stress, increased inflammation, which is that big bad word that we've already heard about, and then impaired lysosomal protein degradation, which could then lead to cognitive impairment. So then again, the question is, could SGLT2 inhibitors impact that? So if you start off then on the far right, here you have SGLT2 inhibitors up on the top right corner, and they of course affect energy balance because of the glycosuria. And by affecting that energy balance, in some ways it's almost mimicking fasting, which then changes SIRT and AMPK in terms of its activation, which then in turn sort of creates this cyclical pattern of anabolism as well as catabolism, which then allows for the mTOR signaling to go back into its cyclical pattern, which then takes away all those negative things of hyperactivation. So again, in theory, this could be very beneficial in the brain. But what do we know clinically? Because again, what I just showed you is predominantly shown in animal models. So what about in humans? So these are the clinical data to date. So the nested case control Danish National Diabetes Register, for those who had ever used an SGLT2 inhibitor versus never used an SGLT2 inhibitor, the odds ratio for dementia is shown for you there. There are also data coming from Hong Kong, propensity score match cohort study, again demonstrating that there was less new onset Alzheimer's dementia, Parkinson's for those who had SGLT2 inhibition versus those who had DPP4 inhibition. And then very recently, there was this paper that was published in Diabetes Care, which took a group of individuals with type 2 diabetes, clinical frailty, as well as heart failure with preserved ejection fraction, and then they received monotherapy, empagliflozin, metformin, or insulin. Now, this was a prospective observational study. And then after just 1 month of treatment, they had their MoCA scores done at baseline and at 1 month. So what is MoCA? MoCA is the Montreal Cognitive Assessment. And you can see with the blue bars that there actually was an interesting increase in the MoCA scores after just 1 month of empagliflozin treatment. And then on the right-hand side, you have the 5-meter gait speed, so looking a bit more at functionality. And again, you see an improvement in the group that had received SGLT2 inhibitor. So interesting human data, clinical data, that is suggestive of maybe benefit from the brain. So mechanistically, animal models, maybe. Human data being accumulated. No really any larger trials that I can speak of in this realm, but certainly something that we can watch out for. So now let's move on to a different organ system. Let's talk about the liver. I don't think any of you are surprised I'm going to mention the liver, again, based on everything that we've already heard this morning. And this next slide is a complicated one that I pulled out of a review article, but just to simplify it, you can just read the list that's on the far right. So the list on the far right sort of summarizes all the various things that we know SGLT2 inhibitors can do. So reduce hyperglycemia, reduce body weight, and thereby reduce insulin resistance. And then the effects then in the liver itself, and I'll let you read them for yourself. But based on all of these data or potential mechanisms, one could imagine that SGLT2 inhibitors could also be very beneficial in fatty liver disease. But I want to focus a little bit on the insulin resistance piece, because I think when I first read about that part in SGLT2 inhibitors, I was admittedly a little bit surprised, because that's not really how we think about SGLT2 inhibitors exerting their benefit. But if they did, it more indirectly so through reduction in weight, et cetera. But this was an interesting paper that was published very recently as well that actually looked at functional MRIs of individuals with prediabetes, not diabetes, but prediabetes, and was actually looking at hypothalamic insulin resistance. And on the right-hand panel, you have the empagliflozin group, and measuring the cerebral blood flow, which was an indirect measure of the insulin resistance in the hypothalamic area. And you can see with the empagliflozin group, there seemed to be an improvement in hypothalamic insulin sensitivity. So what does that translate for the whole body, though? There's some literature to suggest that the hypothalamic insulin sensitivity can also impact from a whole body system as well. Or said oppositely, if you were to improve insulin sensitivity in the brain, that may actually impact how energy is used in the whole body and may impact obesity, et cetera. So again, an interesting potential link that may be there. But if we go back to the liver then, and then think about what kind of clinical data do we have looking at SGLT inhibition and liver disease. So this is looking at SGLT2 inhibitors and GLP-1 receptor agonists, as we heard from Professor Drucker this morning. And you can see that the groups that took GLP-1 or SGLT2 inhibitor on your right-hand side, there wasn't, in fact, a reduction in the FIB-4 score. So the FIB-4 score is a clinical score that looks at several easily accessible clinical parameters and helps to predict the likelihood of a liver fibrosis related to fatty liver disease. And it looks like those who are on GLP-1 and SGLT2 inhibitor fared better. There's a meta-analysis of SGLT2 inhibitors in non-alcoholic fatty liver disease. And what I've highlighted for you are just some of the metabolic parameters or clinical parameters that appeared to be improved. Now, the numbers of studies are also highlighted, not a whole lot of studies, not a whole lot of patients. So these are still definitely early days, but reductions in BMI, in ALT, AST, fasting plasma glucose, FIB-4, which I'll come back to, and then the incidence of other adverse events was also there as well. So certainly suggestive data that there may, in fact, be benefit to be had. And if we look closer at the FIB-4 index, so it says right there in the blue that this is a non-invasive method of predicting actual fibrosis with individuals who have NAFLD. And the FIB-4 cutoffs are shown for you there as well. And what's highlighted in terms of the trials are those 2 trials were in those without diabetes. So not surprisingly, a lot of the NAFLD trials had a lot of people with diabetes in them. But those 2 highlighted ones were people with NAFLD who did not have diabetes. And again, suggesting a reduction in the FIB-4 scores. So therefore, in the liver space, maybe something to look forward to. I think the GLP-1 receptor agonists are further along in in that particular field. However, SGLT2 inhibitors may in fact follow. Where shall we go next? So now let's go to the ovaries. So let's talk about polycystic ovarian syndrome. So this, as you all know, is really metabolic syndrome / insulin resistance syndrome presenting in premenopausal females. So therefore, again, if we think about any therapy that can improve body weight, that can improve insulin resistance, you can imagine there might be improvements as well in the PCOS space. So if we look at the pathophysiology of PCOS, here's another one I've taken from a review article, but I've put into red boxes, again, key words that have already come up over and over in today's conference. So the concepts of inflammation, adiposity, again, inflammation, insulin resistance. So whenever you have a disease state that involves those things, one then has to wonder whether SGLT2 inhibitors may end up playing a role in those disease states, much like GLP-1 receptor agonists seem to as well. But again, do we have clinical data to actually support what I have just said? And believe it or not, there is a meta-analysis of SGLT2 inhibitors in PCOS. And in these studies, these women did not have diabetes. Now, please note that there's very few studies and that the numbers of patients in each of these studies, again, very small. So this is not something that we're going to take to the clinic tomorrow, but I think it is something that is worth watching for. And what in fact was reduced was fasting plasma glucose, even though this group did not have diabetes, reduction in weight, changes in HOMA-IR, as well as reductions in DHEAS. What was not reduced, though, was total testosterone, and some of the other androgens were not reduced, and total body fat was not reduced. But again, very few numbers, 158 individuals across all of the studies, but perhaps something else that we could watch for SGLT2 inhibitors. So next, let's talk about prevention of diabetes. Now this one may be a little bit more obvious as something that one could think about. And we know that there have been many trials looking at prevention of diabetes using a number of different anti-hyperglycemic therapies, and there's no dedicated trial looking at prevention of diabetes with SGLT2 inhibitors. But I'm sure many of you saw this publication that again was fairly recent, which looked at a pooled analysis from DAPA-CKD and DAPA-HF. Now, not surprisingly, in this CKD population, in a heart failure population, they had people with diabetes, but they obviously had people who did not have diabetes. And therefore, it was pre-specified to take a look at these two studies together to see whether dapagliflozin would impact new onset diabetes. So this is a reminder for you of sort of who was in those particular studies and the dapagliflozin group and the placebo group. But one thing I wanted to point out is when they just extracted those patients who did not have diabetes, you'll notice, though, that 59.6% or 60% of the non-diabetes group had prediabetes. And the reason I want to stress this is that as I show you the outcomes of this pooled analysis, bear in mind that most of these people had prediabetes. But I think the other clinical point to take away is that we need to be screening for dysglycemia in any of your patients with CKD or heart failure. And I'm going to add to that atherosclerotic cardiovascular disease. Very high prevalence in that population. So here, the majority of these individuals did, in fact, have some form of dysglycemia, but the mean A1C shown on the bottom was about 5.7%. So what was shown? So here you have the cumulative incidence of new onset diabetes on your y-axis, and you've got time on the x-axis, and in the blue is the dapagliflozin group, and in the red is the placebo group. And a clear reduction in new onset diabetes in the group that was receiving dapagliflozin. However, bear in mind that greater than 90% of the progression to diabetes were in those with prediabetes, not surprising. But given how prevalent it is in the CKD and the heart failure population, this is still something we need to be considering. But of course, a very important question that you're probably thinking is, well, how much is masking and how much is true prevention? And this has been a question of every drug we've ever looked at from the perspective of diabetes prevention. And I don't think we can ever really answer this question without further studies, but a couple of points I would raise is if we're looking at A1C change over time, so there's the two groups there. So the upper line represents the prediabetes group, the lower line represents the group who had true normal glycemia going in. And you can see that there's not much separation in the A1C curves between the dapagliflozin and the placebo groups within each of those glucose categories. So that's reassuring that maybe this is less likely to be masking and maybe more likely to be true prevention. And then the other piece of clinical information I would bring is the percentage of individuals who had eGFRs below 45. And as you all know, with eGFR below 45, the amount of glucose reduction that an SGLT2 inhibitor provides is much less. Therefore, again, less likely to be just masking of hyperglycemia, but maybe something mechanistically there. So too early for any of us to say that this is to be used as a diabetes prevention drug, but interesting food for thought nonetheless. And then the final organ system I'm going to bring up is the eyes. So obviously diabetic retinopathy is an important consideration in our patients living with diabetes. And if we look at the pathophysiology of how one develops diabetic retinopathy, I just want you to notice the red words. So hypoxia is an important component of developing diabetic retinopathy. And there's an interesting discussion, this was in 2021 in JCEM, that kind of looked at, okay, well, could SGLT2 inhibitors perhaps play a role here? So they might play a role in terms of reducing the metabolic parameters that we know can contribute to retinopathy, such as, of course, hyperglycemia and blood pressure. But perhaps there's other ways that it could do it. So improved glucose control can also have benefit, but then also the whole ketone thing, the whole ketone story. I shouldn't call it the ketone thing, the ketone story that has come out, and in terms of energy use, and whether that could have a benefit in terms of reducing hypoxia. So again, interesting hypothesis, studies need to be done. So what do we know from a clinical perspective? Well, there are case reports like this that look really, really impressive. So here, this is looking at pre-SGLT2 inhibitor up top, 1 month, 6 months, 30 months, and red is bad. That much I could figure out, not being an ophthalmologist. And then there's less red as one gets on the SGLT2 inhibitor. Now, these are case reports. Obviously, you take this with a huge grain of salt. However, interesting hypothesis. And then there are some data here looking at a retrospective cohort study from Taiwan showing less development of diabetic macular edema amongst those taking an SGLT2 inhibitor. Again, you're going to interpret this very cautiously. But these kind of data would lead to clinical trials like these, where SGLT2 inhibitor is not being used as the sole therapy for macular edema, but as adjunctive therapy with other therapies that have been shown to be beneficial. So something else for us to watch for. Now, there's lots of possibilities then, and there's more that I could potentially talk about beyond what we already know. Diabetes, CKD, heart failure, we know these now, but there may be other therapeutic areas that we can watch for. But one thing that I want to end off with is all of that's great, and it's fun to talk about, it's fun to read about, it's fun to look forward to. But we're not even using it where we know it works. And Dan alluded to that already in his lecture. And now these are data looking at Canada, and I'm from Canada, so I can sort of bash what we're doing, but I'm going to show you data that no other country is any different. So this was looking at Canadian database and the percentage of individuals who would qualify for guideline-directed therapy with either GLP-1 receptor agonist or SGLT2 inhibitor, and the percentage that wouldn't. So in the green would be those who would have no cardiorenal indications, and then the red, secondary prevention and primary prevention. And then the use of GLP-1 receptor agonist or SGLT2 inhibitor, so 19.4% amongst those secondary prevention, 16.6% amongst those primary prevention that would still qualify because of multiple risk factors, and 20% in those who didn't have any indication. So in other words, it didn't matter. It didn't matter. What it should have been was nearly 100% in the secondary prevention and in those qualified primary prevention, and then there should still be a percentage with no indication, but not similar. But this is not specific to Canada. These are data from the CAPTURE study that, again, many of you may have actually been involved in, looking at data from 13 countries, and those with diabetes and those with cardiovascular disease, diabetes and cardiovascular disease, or diabetes and no cardiovascular disease. And again, you see really no difference in the percentage of people actually using guideline-directed therapy. So before we start talking about hepatology, ophthalmology, gynecology, neurology, maybe we need to fix here and actually still use the stuff where we already know it absolutely works. So back to the original question then, SGLT inhibition, are there no therapeutic limits? I mean, there are therapeutic limits to everything, but obviously it's starting to push the areas. It may have been born in the diabetes space, but has grown up and has visited other friends and made other friends and will continue to make other friends. But just a word of reminder to all of us in the room as clinicians is we still need to encourage ourselves and our colleagues to use them where we have definitive proof while we excitedly watch for future data. Thank you very much for your attention.